Okay, chapter 10, review questions. Let's look at some of these. So breathing is controlled by an area in the lungs, in the brainstem, in the spinal cord, or in the diaphragm. So first off, let's figure out what they want to find out. They want to know where the breathing is controlled by an area in the blank. In the lungs, brainstem, maybe kind of the lungs are the muscle doing the action. The brainstem, kind of the brain center of what's going on. Spinal cord, just kind of the highway for the cars to go down. Or the diaphragm, another muscular organ. Let's get switched over here. Hang on, sorry. So answer B. The pons and the medulla are the respiratory centers in the brainstem that control breathing. Now let's take a look at what's right and what's wrong. Breathing controlled by an area in the lung. So the lung contains small pockets called alveoli. Remember those little berry-like sacs where the exchange of oxygen and CO2 take place. So it's not controlled by that. That's where the magic happens, okay? Brainstem, that is the correct answer. And then the spinal cord. So the impulses are sent down the spinal cord from the brainstem, kind of how we mentioned, almost like the highways for the impulses to go to. And then the diaphragm, that's actually the organ that's receiving it. So once again, breathing is controlled by an area in the brainstem. The EMT should assess a patient's tidal volume by A. Observing for adequate chest rise. B. Assessing the facial area for cyanosis. C. Counting the patient's respiratory rate. Or D. Measuring the patient's O2 saturation. So first off, what are we looking at? We want to assess a patient's tidal volume by, so adequate, right? Adequate ventilation. That's what we're looking for. And I think we've mentioned it multiple times. Hopefully, what are you thinking right now? Say it out loud. Yes. A. Observing for, what did it say? Observing for adequate chest rise. So the tidal volume, the volume of air that has moved into or out of the lungs in a single breath, is assessed by observing for adequate chest rise. So if shallow chest rise is noted, the patient's tidal volume is likely reduced. We should see equal chest rise and fall. So the EMT should assess a patient's volume by observing for adequate chest rise, yes, assessing the facial area for cyanosis. That's not necessarily telling us about tidal volume or the amount of ventilation that's going on. That's an indication of hypoxia. Cyanosis is not tidal volume. Counting the patient's respiratory rate. Counting the respiratory rate gives you the minute volume, which the number of times a patient breathes in 1 minute. Doesn't tell us anything about how much air they're moving and all of that. And then measuring the patient's O2 saturation. So that's the next thing, right? When we start talking about respiration, that cellular metabolism stuff. O2 saturation is an indication of tissue perfusion, which is the amount of oxygen attached to the hemoglobin. So that's not helping us either with the O2 saturation. Here we go. In an otherwise healthy individual, the primary stimulus to breathe is a increased level of O2 in the blood, a decreased level of O2 in the blood, an increased level of carbon dioxide in the blood, and a decreased level of carbon dioxide. What we want, otherwise healthy individual. So it's just saying these people, this guy's fine. The primary stimulus to generate, it's what causes you to breathe is. We've talked about this in class. Increased level of O2, decreased level of O2, increased level of CO2, decreased level of CO2. So what do you think? Give you a second here. What? I heard an A. Oh, I don't know. Come on, guys. Let's think about that. Yes, you're right. C. So under control of the brainstem, rising levels of carbon dioxide in arterial blood normally stimulate breathing in an otherwise healthy patient. So we've talked about that CO2 being the main thing that actually causes us to breathe, and that's where we get the hypoxic thing about flooding to people with O2 and all of that. But let's take a look at why these other answers may or may not be right. Increased level of oxygen in the blood. Well, the increased levels of oxygen can be a result of hyperventilation syndrome, so that's not the reason. The decreased level, this is typically not normal in healthy individuals. It can be a sign of inadequate breathing, and it results in hypoxia. It doesn't result in, breathing faster, all of that. In an otherwise healthy individual, primary stimulus to breathe is an increased level of CO2, and decreased this is usually not seen in healthy adults, typically a result of hyperventilation syndrome. Very good. Now, signs of adequate breathing in the adult include all of the following except, now look at your big letters here, except. So let's take a look at what we got here. We've got include all of the following except, okay? Signs of adequate breathing include all of the following except. Pink, warm, and dry skin. We know that's normal, right? That's good, adequate breathing. Pink, warm, dry skin, kind of a side effect of it, rather. Or a sign, I guess. Shallow chest rise. When do we want shallow chest rise? That's kind of throwing up a red flag there. Symmetrical chest movement. That's something that we're hoping for in adequate breathing. And a respiratory rate of 16 times a minute. Wait a minute. No. Respiratory rate of 12 to 20. So that's just right there in the middle. So let's take, what are we thinking? I agree. B. B is the answer. Signs of inadequate breathing in the adult. Less than 12, greater than 20, shallow chest rise or reduced tidal volume, cyanosis, asymmetrical chest movement. So pink, warm, and dry shows everything, or shouldn't say everything's going right, but it's pretty, in this situation it is. It shows that breathing and perfusion are adequate. Symmetrical chest movement. This shows the mechanical process of breathing is adequate, equal, and symmetrical. And then a respiratory rate of 16, that is a normal respiratory rate. So during an insertion of an OPA or an oral pharyngeal airway into an unconscious patient, she begins to vomit. The first thing you should do is turn the patient on her side. Doesn't seem like a half bad idea, right? Remove the airway at once. Not a horrible idea as well. Suction the patient's mouth. Use a smaller sized oral airway. What do you guys think? This one might throw you off here. So we've got a couple of answers that look pretty good, and I've heard, well, I see multiple right answers, correct, but we've got one that's 100% correct, and then others that have correctness to them. Rationale A. Whenever an unconscious patient begins to vomit, whether you're inserting an OPA or not, you should immediately turn the patient onto his or her side. This will allow drainage of vomit from the mouth and prevent aspiration. After the patient is on his or her side, remove the oral airway and suction the mouth out. So we want to do that first. We want to roll them over on their side first thing. So remove the airway at once, remove the airway after the patient has been rolled. We want to get them over first. And then suction a patient's mouth. This must be completed after the patient is positioned and the airway is removed. And then use a smaller one. Well, OPAs are contraindicated if the patient has a gag reflex, so we don't want to use a smaller one. And we also want to use the right size, kind of the right tool for the right job, right? In which of the following patients would a NPA or a nasopharyngeal airway be contraindicated? A semi-conscious patient with a gag reflex, an unconscious patient with an intact gag reflex, a patient who fell 20 feet and landed on his or her head, or an unconscious patient who gags when you insert an oral airway. A lot of these are actually the exact opposite answer, right, of what's right? Excuse me. What I'm trying to say is there's one that's very clear for here, and some of these others are actually okay answers. So what we're saying is NPA, airway would be contraindicated if an unconscious patient, a semi-conscious with gag, unconscious with an intact gag, patient who fell 20 feet, landed on his or her head, Unconscious patient who gags. So what do you think? I'm going with C. I remember when we talked about NPA that we're thinking about head injuries, and we don't want to use an NPA with head injuries. Let's see what we got. Boom! Nasal pharyngeal or a nasal airway are contraindicated in patients with severe head or facial injuries and should be used with caution in patients who have delicate nasal membranes or prone to nosebleeds. The nasal airway is better tolerated in patients who are semi-conscious and or those with a gag reflex, which is all of our other patients, I believe. Semi-conscious patient with a gag, this actually works really well with them. An unconscious patient with a gag, this actually works really good with them. C is the correct answer. And then unconscious who gagged when you insert an oral airway. This airway can be used when the patient gags with an oral airway. So it was a good answer for all the others, but definitely not the head injury. Let's look at one more. So you are delivering oxygen to a patient with a nasal cannula at 4 L per M, mins. What's this mean, guys? 4 liters per minute. This is our dose of oxygen, 4 liters a minute. When he begins to complain of a burning sensation in his nose. Now, that sounds kind of weird. So let's take a look here. A, you should remove the nasal cannula. You think he might be having an allergic reaction to oxygen? I don't know about that. I don't know if we want to remove the nasal cannula. Let's keep moving. Apply a non-rebreathing mask. Well, I don't know what that's going to solve. We're still giving them lots of O2 and actually giving them a lot more this way. Attach an oxygen humidifier. Now we complain of a burning sensation. Maybe, I wonder if it could be, he's like dried out and he needs to have some humidified O2. Or increase the flow rate to 6 liters a minute, because that'll fix it. Because if I'm giving you this and that causes a problem, if I turn it up even higher, then that fixes it. Nah, that doesn't make sense. So it's definitely not that. C, administering dry O2 through a nasal cannula, especially over a prolonged period of time, can result in drying of the nasal membranes, in which the patient might complain of a burning sensation. Humidified O2 will serve to keep the nasal membranes moist. So, remove the nasal cannula, oxygen should be humidified. That's not going to fix anything, guys. If this person needs O2, this person needs O2. Apply a non-rebreather. Well, the problem is that's not changing anything. Actually, could be potentially making it worse, because we're giving him more pure O2 at probably a higher rate too. So this can still cause an irritation because it's dry O2. Attach an O2 humidifier and then increase the rate. And then once again, the O2 should be humidified. Okay, fine. We'll do one more. So a patient is found unconscious after falling from a 3rd floor window. That's not good. That's a pretty good ways up there, isn't it? Probably at least, 40 feet or something. Respirations are slow and irregular. Let's see what we should do. You should, patient is found unconscious. Sick or not sick? You got it, sick. He fell from a 3rd floor window, multi-system trauma, right? So we could have a broken neck, we could have broken bones, he could have broken some ribs and lots of stuff. So this guy's sick. So first thing we want to should we place him in the recovery position? I don't know about that. It doesn't seem like maybe a great idea, placing him in the recovery position. Doesn't say anything about vomiting, and he fell out a 3rd floor window. Apply O2 via a non-rebreathing mask. I don't know about that either. Suction his airway for up to 15 seconds. We don't see a reason, right? I mean, we're not seeing a reason here to suction his airway. Assist his breathing with a BVM or an ambu bag. Let's see, he's found unconscious and his respirations are slow and irregular. So what do you guys think? Yes. Well, wait. Now I heard somebody say A, place him in recovery position. No, I don't think we want to do that. Let's go to D. Assist his breathing with a bag valve mask. Let's see what the EMS guru says. Answer is D. Patient is not breathing adequately, right? Slow and irregular will not result in adequate oxygenation. You should assist the patient's breathing with a BVM or a bag valve mask attached to 100% O2. Suctioning is indicated if there's blood or other liquids. There's no evidence of that. So if it said that he was gurgling on fluid, that we would definitely want to do some of that, right? We want to get that stuff out of there, but that's not what we found. So recovery position due to significant MOI, what was that? Mechanism of injury. The patient will be placed supine on a long board with the head immobilized. Apply oxygen. Well, a BVM is indicated if the patient's respirations are less than 8, not necessarily a non-rebreathing mask. We're going to probably need more than that considering that he was sick. And then C, suction his airway. It's indicated if you need to, if you have a reason. Right here, we didn't really have a reason. Assist his breathing with a BVM. Yes. Okay, you guys talked me into it. Let's do one more. Maybe even two. I don't know. Let's see. Let's get crazy. When ventilating an apneic adult with a BVM, you should squeeze the bag. Okay, here we go. This sounds like something we were talking about in class, doesn't it? When ventilating an apneic, what's that word, guys? Apneic means somebody not breathing, without breath. Apneic adult with a bag valve mask. You should squeeze the bag until it's empty. Do we want to empty that sucker out? Remember, we talked about tidal volume being around 500-ish. We also talked about an adult bag being around 1,000-ish. Okay. You should squeeze the bag, B, over a period of 2 seconds. Squeeze the bag at a rate of 20 breaths a minute. Okay, let's talk about that for a second. That almost seems a little fast, doesn't it? Because we wanted to do it once every 5 seconds. So I don't know about that. And then D, until chest rise is noted. Once again, adequate ventilations. Okay, ventilating an apneic adult with a BVM. What do you think? I hear it. I can, oh, ding, 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 ding. Oh, everybody, every one of you guys said until visible chest rise is noted, and you're right. When ventilating an apneic, a patient with a BVM, you should squeeze the bag over a period of 1 second and observe for visible chest rise. Ventilate the apneic adult at a rate of 10 to 12, 1 breath every 5 seconds. Ventilate infants and children at a rate of 12 to 20, 1 breath every 3 seconds. Very good. We're picking up on that. I hope you guys are seeing a trend of how important this is. We've talked about this in class as well as this particular little review here multiple times of what adequate ventilations look like. So let's look here. Until it's empty, an appropriate size bag for an adult will not totally empty. Okay, we kind of talked about that, didn't we? Over a period of 2 seconds. Well, we kind of mentioned that might be a little bit long, but you should squeeze the bag over a period of 1 second. Number 9, or we're still on 9, or on C, a rate of 20 breaths a minute. Ventilate the apneic or adult rate of 10 to 12. So that's a little fast. That's hyperventilating by default, by definition rather. And then until visible chest rise is noted, and every one of you guys are almost like baby EMTs now. You're getting this stuff until visible chest rise is noted. And because you got that one right, we're going for the bonus. Bonus round. You and your partner are ventilating an apneic adult when you notice that his stomach is becoming distended. Oh, not good. Okay, so we got 2 people, you and your partner, 2-person CPR here, ventilating an apneic adult when you notice his stomach is becoming distended. Let's talk about what we want to do. You should. So what should we do? Remember, maybe all 4 of these guys are going to be somewhat right, but only one's going to be really right. A, suction his airway for up to 15 seconds. Well, I don't know. I almost feel like they're trying to trick us. Suction, we think we might need to throw some suction in there, get that belly drained, but I don't know. B, reposition his head. Well, we could definitely reposition his head. C, increase the rate and volume of your ventilations. We already got a problem, so let's do this. Okay, here's the problem. We're driving down the highway at 60 miles an hour, and our motor starts making a noise, and the check engine light comes on. So I look over at you and say, hey, floor it. And that doesn't seem like a good idea. Increase the rate and volume doesn't seem like a good idea. Or decrease your ventilation rate, but use more volume. So do it slower, but more air in. That's kind of wacky. Now, I can't say that we've ever talked about that, have we? So what are we thinking? It looks like we got a couple that could be pretty good answers. So right away, we can mark out C, can't we? We don't want to turbo boost our broken engine. And then D, we've never heard, decrease your ventilation rate, but use more volume. That really doesn't make any sense, does it? So we got A and B, suction airway for 15 seconds. So hang on. If we suction his airway, what are we going to get out? I don't know if that's a very good answer because we're not wanting his airway cleaned out. We're wanting his belly cleaned out, right? If we're going to use suction, I think we should go with reposition his head. What do you guys think? Because we've talked about that. If we're doing good ventilations and good airway management, epiglottis should be shutting things down so we get air in the right place. All that, right? Sounds familiar? Oh, boom. Answer is B. Gastric distension occurs when air enters the stomach. Severe gastric distension can result in vomiting and aspiration if not recognized and treated. To minimize the amount of air that enters the stomach during ventilations, you should reposition the patient's head. Good work. So A, suctioning is indicated when there is blood or secretions in the airway. We got that. B, reposition his head. We also answered that correctly. And C, increase the rate. The action may result in even more air going in the stomach. Yeah, we don't want that. And then D, action may result in even more air going into the stomach. Well, that's it, guys and gals. 10 review questions talking about each and every one of them. And you guys did very well. So I will see you soon. Signing out.